My name is Peter Voorhees, and I'm a myeloma investigator at the Levine Cancer Institute in Charlotte, North Carolina. So today I'm going to be talking to you about the results of the safety run-in cohort from the Griffin trial, which is a randomized phase 2 study evaluating daratumumab in combination with Revlimid, Velcade, and dexamethasone for transplant-eligible patients. So we all know that survival has improved for multiple myeloma patients in recent years. A good example of this is data from the IFM 2009 trial, where patients received RVD induction therapy followed by transplant, RVD consolidation, and Revlimid maintenance therapy. And what they saw in that trial is that the complete response rate was 60% in the transplant arm, with a median progression-free survival of 50 months. But I would argue that there is still room for improvement. We know that daratumumab is an effective monoclonal antibody in the relapsed refractory patient population as a standalone therapy. We also know that when you add daratumumab to standard of care regimens for multiple myeloma, you improve the overall response rate, you improve the depth of response, and that typically translates into improved progression-free survival. And this has been seen not only in the relapse setting, but in the newly diagnosed setting as well. So we thought it was only a natural fit to include daratumumab into the Revlimid, Velcade, dexamethasone backbone for patients with newly diagnosed multiple myeloma who are eligible for transplant. So the first thing that we wanted to do is prove that it was safe, not only from a side effect perspective, but also with regards to stem cell mobilization and engraftment in the context of stem cell transplant. So we had a 16-patient safety run-in cohort, and that was the basis of our presentation. So what I can say is that in general, the regimen was well tolerated. The side effect profile was very much in line with what you would expect to see when you add daratumumab to Revlimid, Velcade, and dexamethasone. We did have a relatively high number of infections in these 16 patients, but I would urge a bit of caution there in that these patients have actually been on therapy for quite some time, and the majority of the infections were low grade in severity. That said, we did see 4 patients experience pneumonia, so 25% of our patients experienced pneumonia, at some point in the course of the therapy. The other thing that I'll mention is that it does not appear that stem cell mobilization and engraftment was negatively impacted by adding daratumumab into the regimen. So the median number of stem cells that were collected was 8 times 10 to the 6 CD34 positive cells per kilogram. Median time to neutrophil engraftment was 13 days, and median time to platelet engraftment was 13.5 days. So clearly it appears that you are able to collect stem cells effectively in the situation. I think the most exciting thing is the response data that we've reported. Now granted, it's just with 16 patients, but at the end of induction, the overall response rate was 94%, and 56% of patients had at least a very good partial response, with 6% non-stringent complete responses. But what we see is that over the course of therapy that the responses deepen over time. So at the end of post-transplant consolidation, the overall response rate was 100%. All patients were in at least a very good partial response, and 63% of the patients had either a non-stringent or stringent complete response. And then when we go into maintenance therapy, I'm excited to report that 15 out of 16 patients were either in complete response or stringent complete response, and 63% of patients were in stringent complete response. And at the time of cutoff at the end of October, only 1 patient in the safety run-in has progressed. So would I change practice based on these data? No. It was only 16 patients, and one thing that I didn't mention earlier is the fact that 3/4 of these patients had ISS stage 1 disease. So I think it's early days. It's very encouraging, but we have to wait for the randomized data before we change practice. And in that regard, I'm happy to report that the randomized portion of the Griffin trial completed enrollment earlier this year, and we hope to have those data available to you in 2019.